Welcome, everyone. Thank you so much for joining us today for this educational patient webinar. The title of our webinar today is Living with Heart Valve Disease. And if you are joining us for the first time, thank you so much. We're so glad you're with us. And welcome back to everyone who's been attending our webinars so far. We've had a great response, and we're so excited to be providing this great information for all of our patients. And just to introduce Heart Valve Voice for people who are new, we're a patient-led organization that exclusively focuses on improving the diagnosis, treatment, and management of heart valve disease. And we advocate for early detection, meaningful support, and timely access to appropriate treatment for everyone that's affected by heart valve disease. And we do encourage you to find us online at heartvalvevoiceus.org. And you can sign up for updates and to get emails about the webinar series that we're having. And you can also find us on Facebook and Twitter. And my name is Susan Strong. I'm the Director of Patient Engagement at Heart Valve Voice, and I'm also a patient. This November 12th will be my 5-year anniversary for having TAVR, transcatheter aortic valve replacement. So pretty soon, my TAVR is going to be 5 years old. And we are so fortunate today to have a passionate practitioner who cares deeply about patients and who's giving her time today to share some really important information with us. Tricia Keegan has her doctorate in nursing practice. She's a structural nurse practitioner. She's the lead nurse practitioner in the structural heart program at Emory. And we are so fortunate to be able to sit down with Patricia for an entire hour and talk about heart valve disease. So Patricia, welcome. Thank you for being here.
Thank you. I'm so honored to be a part of this. So thank you so much for reaching out and allowing me to participate. It's very funny. I was always meant to be a nurse, and many people say, once you get your doctorate, what made you not become a medical doctor? And that's because I have always been passionate about nursing care and just really being holistic, treating the patients first and foremost, and then being able to help with disease process, but really what is most important to the patient. So again, I'm exceptionally grateful and honored to be here today as a part of this program. So what we're going to do is just talk about aortic stenosis and really just go over what are the symptoms, talk about the testing that's necessary, what are some potential treatments, really branch into mitral valve disease a little bit, and then also just discuss some post-procedure follow-up and care. Next slide, please.
That sounds great. And I'll jump in and just say, Patricia and I have talked about making this kind of conversational. So as the presentation goes along, I may jump in and ask a couple of clarifying questions, or we may save it to the end. We'll see how it goes. But just to warn everybody that we may be a little conversational in this today.
Absolutely. And please don't be afraid to reach out. Obviously, I don't know people's individual cases, but we can talk in generalities and kind of what's going on and what some information might be. So the first thing that we have to talk about is the heart, and that's what we're here for. And the heart actually has 4 valves. There's 2 on the right side of the heart and 2 on the left side of the heart. And so when blood comes from the body and goes back into the heart, it goes from the top right side of the heart through the tricuspid valve to the bottom right side of the heart, through the pulmonic valve, into the lungs where it gets that oxygen, into the top left side of the heart, goes through the mitral valve, and into the bottom left side of the heart, and then out through the aortic valve. So you can see where these valves are really important, because what they're designed to do is let the valve open so that blood can go through, and then close so that blood doesn't back up. And that's why when we talk about problems with the heart valves, how this can really affect how that heart functions. Next slide, please. So I didn't want to be remiss and not talk about coronary disease at all, because this might have something to do with the valvular heart disease. So sometimes if you have blockages in heart arteries, that can make the valves work worse. And so we do take a look at that. And then people talk about, well, what's the difference between bypass or PCI, which is stenting? So when we talk about the different blood vessels, the location of the blockage has something to do with it, and there's options for treatment. So some people might need to have open heart surgery, especially if they have more than 2 to 3 vessels blocked or are a diabetic, or they might be an adequate candidate for stenting, which is also called a PCI, or a percutaneous coronary intervention. There's also a hybrid procedure where they might do a bypass on the left anterior descending, which is the big artery in the heart, and may be able to stent other procedures. So again, working with your team to see what those different options are for treatment is going to be really important. And it all depends on where that blockage is as well. Next slide, please.
Tricia, could I ask you a quick question about the
Of
previous
course.
slide? The procedure that you talked about last with the bypass in the graft on the left side, is that
Right.
a minimally invasive type
It
surgery
is
or
a
what?
minimally, right. So some people call it an off-pump bypass because you don't have to go on the heart-lung machine for that procedure. Or, so what they do is they use a robot in some cases to do the hybrid procedure. So what that means is they're going to do the surgery part of it for the left anterior mammary artery. So they're going to put, it's affectionately known as a lima, to the left anterior descending. So pretty much kind of what they're showing in that picture there. They're going to do that, but they can do that minimally invasively. And then what they do is, say a patient has a blockage on the right side of the heart, they can just put a stent in there. So that is considered a hybrid procedure.
Oh, thank you so much. That is good information for me to learn.
So when we talk about valvular heart disease, there's really 2 different kinds of valvular heart disease, and this is true for any of the valves. You can have stenosis, or you can have regurgitation, or sometimes it's called I can't even speak anymore, insufficiency. And so if you have aortic insufficiency, that means that the valve is leaky. It's regurgitant. Another time, if somebody says they have mitral valve prolapse, a lot of times that means regurgitation as well. So if you have any concerns or questions about what type of valve disease you have, because they're using a word that isn't one of these 2 words, don't be afraid to ask, because it's important to know if your valve is leaky or if it's stiff. So next slide, please. So when we talk about valvular heart disease, it can be mild, it can be moderate, severe, or critical, and that is very dependent on the measurements. It doesn't necessarily have to do with how loud a murmur is. There are some people who have a very loud murmur who might only have moderate disease, and especially in regurgitant, because you can't hear that blood flow across the valve, it doesn't necessarily mean that your valve is super leaky if you have a loud murmur. And patients may be symptoms or they may not have symptoms, and it just all depends. So you have to look at not only the numbers, but also treating the patient, not just the numbers. Next slide. So we're going to talk about aortic stenosis first. So aortic valve is the valve that we talked about between the left ventricle and the aorta. And as blood leaves the heart, it goes through the aortic valve into the aorta and then to the rest of the body. So what happens is that aortic valve usually opens and then closes, so blood does not go back into the left ventricle. And if you have aortic stenosis, that valve doesn't open fully, and as a result, this decreases blood flow from the heart. And again, you can have mild, moderate, or severe, and in some cases, patient might have critical aortic stenosis, and again, that has to do with a measurement that we'll talk about in a minute. Next slide. So in this, it just shows about what aortic stenosis is. So normally when we're made at the factory, the valve has 3 leaflets. There are some people who might have 1 leaflet, 2 leaflets, or even 4 leaflets. But most commonly, patients have 3 leaflets. And you see in the stenotic valve in this is called senile calcific aortic stenosis. And all that kind of orangey area And where it looks kind of wrinkly is all calcium that has built up on the valve, and it prevents that valve from opening nice and wide. So a lot of times when we're talking to patients, what we say is normally that valve should be open about the size of a nickel to a quarter, and in patients who have aortic stenosis, that opening might only equal that of a drinking straw. So you can see why people get symptoms with their valve not opening wide. Next slide. So how many patients have aortic stenosis? So somewhere in the neighborhood of 4 to 5%, and you'll see many more people have mitral valve disease than aortic stenosis. But again, that mitral valve disease is accounting for not only just stenosis, but also regurgitation as well. Next. And it's important to note that even when they looked at a couple of years ago, there's about 500,000 people who live in the United States who have aortic stenosis, but only about 50% of those patients have symptoms. So people may have aortic stenosis who don't even realize it. Next slide. So what causes aortic stenosis? Most times, we like to have answers for everything. How could I prevent it? And unfortunately, aortic stenosis isn't really preventable at this point. So sometimes it can be genetics, and those patients, especially if they're born with the 2 leaflets instead of 1 leaflet, they tend to develop stenosis a lot faster than the older population. There is some immune response that we believe is responsible, so just that environmental challenges, age. If you've ever had rheumatic fever or infective endocarditis, they can lead to aortic stenosis. And then especially people with a history of cancer with radiation to the chest. And this is mantle radiation. And especially we see a lot of patients in the 70s and 80s who come with this, who the radiation was so good to help treat their cancer, but unfortunately it left a lot of calcium in even the blood vessels or on the heart valves themselves. Next slide. So what are some symptoms of aortic stenosis? So it's very general. So a lot of times patients have shortness of breath, and it's especially with activity. And unfortunately, this symptom is progressive. It continues to get worse and worse and worse until the patient just can't even get up without feeling short of breath. A lot of times they can have chest pain, especially with exercise. And if they sit down and rest, that blood flow gets better. And so they do get relief of the chest pain. And it feels like it's right under the breastbone, but it can radiate into the left chest. Sometimes they might have passing out episodes or extreme lightheadedness, fatigue, or even palpitations. And this is really, really difficult because the problem is in my practice, I happen to see a lot of patients in the upper 70s, maybe 80s. And even when we look at who was treated with transcatheter valves, especially earlier on, the average age was about 84 years old. And so when these patients go to their doctor, they don't have an expectation that they're going to feel good. They don't have an expectation that they're going to feel like they did when they were 50. And so they think that fatigue and that shortness of breath is a normal part of aging, and it's not. Or the other challenges is a lot of times you go to a doctor that you've been seeing for a long time, and maybe they only have 10 to 15 minutes to spend with you. And so these visits are very quick, and has anything changed? And patients don't even think about bringing it up like, hey, I'm feeling more tired, or it's really weird. I was walking up the hill the other day and I'm feeling short of breath. And it's not very, insidious, or it's not very a lot, and it starts off slower. But if you go back and look at these patients over the past 3 to 6 months, there's a definite difference in their activity level because of that shortness of breath or because of that fatigue. Next slide.
Trisha, what you're describing there sounds to me like the frog in the boiling pot of water. That's what happened with me as well. The symptoms creep up so slowly that you don't notice the change.
Absolutely. And it's very, very challenging because you have patients who come in and you really have to sit there and ask, what about if do you feel shortness of breath when you walk? No. What about if you walk up a hill? Ooh, then I have to go slow. What about if I ask you to go up a flight of steps? Oh, I can't do that. So, again, sometimes it's just how much that questioning is. And so that's why I tell patients it's so important to kind of know you, because you know you more than anybody else knows you. And so
Mm,
what we talk about is really just making sure that you're having honest conversations with how you feel, because a lot of times, again, people think it's okay to be tired. And we all have those days where we just feel like, boy, could really use a nap. But if it's happening every day and that's a change for you, that's something that really needs to be brought to the attention of your provider.
that's a great point. Thanks.
So when patients come into the office, a lot of times what we're going to hear is something called a murmur. And depending on where we put our stethoscope on the chest, and depending on whether it's with the first or second heart sound, it gives us a lot of good information of, is the valve leaky or is the valve stiff, and really what valve it is. So a lot of times when we listen to patients who have aortic stenosis, the left upper sternal border, and it's a very harsh murmur, and we hear it with that first heart sound. So when we hear that murmur, the first thing that should happen with your primary care physician or your practitioner is to go for an echocardiogram for confirmation. And a lot of time it's the murmur is not the disease. The murmur is just a symptom that something is causing that blood flow to be turbulent over that area. So depending on where a blockage might be, we might hear murmurs in a lot of different areas. If you have an aortic aneurysm in your belly, sometimes we can hear the blood flow across your belly. If you have a blockage in the arteries of your neck, a lot of times we can hear the blockages there too. And when we put our stethoscope on your neck, what we're listening for is that blood flow. And sometimes aortic stenosis murmurs, you can hear it up in the neck as well. It radiates. We're going to check you and see if you have swelling. A lot of times I'm going to ask you about your eating, if you're getting full early, if you're having palpitations, if you're having any bleeding. And what we've seen in a lot of these patients who have aortic stenosis, at times, especially in the original kind of days of the partner trials, we saw more patients come in who had bleeds. And there is an association between having severe aortic stenosis and having a GI bleed. So that is something that we would look at as well. Next slide.
Mm,
So when we have a patient who comes in, and of course, I work for a valve center. So when I get patients through my door, they typically have valvular heart disease. So a lot of times if you're seeing a cardiologist for a heart valve problem, they may start off with an echocardiogram and something called an EKG. Next slide, please. So we're going to talk about an echocardiogram first. And basically what an echocardiogram is it's an ultrasound of your heart. And what we do with this is we use ultrasound waves. So there's no radiation with this test. We use this ultrasound to look at the heart valve and get different measurements. Next slide, please. So again, when we talk about, how the patient feels, we correlate it with numbers. And so basically what the jet velocity is, how fast is the blood going across your aortic valve? So people who don't have aortic stenosis or just have mild, that blood flow, if you thought of it as kind of spitting out, would go less than 3 meters a second. And people who have severe aortic stenosis, a lot of times we see that greater than 4 meters a second. So that blood is kind of spraying out inefficiently. And a lot of times we tell patients that it's kind of like having a finger over the garden hose. So you might get some spray out, but it's not efficiently watering your lawn. We also look at the gradient, which again is the pressure between the top and the bottom of the heart valve. And, sometimes we explain this as if I had to take a blood pressure cuff and I had to press it every single time that your heart had a beat, how much pressure would I have to put on it? And so people who have mild or less aortic stenosis, that mean gradient is less than 25. And a lot of times patient will come in and we'll see maybe 10. However, if you have severe aortic stenosis, it's greater than 40. And so you have to think about this, that when you're at home and people are feeling tired, their heart is kind of running a marathon, even though they may not be having activity. And a lot of people feel like, oh my gosh, what I have to do is I have to get out and I have to be more active. but increasing that cardiac output actually doesn't help in patients with severe aortic stenosis. It can actually harm them. So that is something to work with your team about. We also look at that valve area, and just like we talked about before, the normal opening should be about the size of a nickel to a quarter. And that valve area, if we see that it's less than 1 centimeter squared, that tells us that it's severe. And then there's a special thing called valve area index. And where this is really important is you have to think about this. If somebody is 5'2" and weighs 100 pounds and they have an area of 1 centimeter squared, their blood flow actually might be okay and they might not be very symptomatic. However, if I have somebody who is 6'3" and weighs 300 pounds and has a valve area of 1, they have to account for that body surface area. And so those patients actually might have a much more narrow area dependent on their body size. So that's where that indexed valve area comes in really, really handy, because if I just looked at everybody and said that magic number is 1, I might miss patients who really do need my help. Next slide. We also look at ECGs, and the reason is that when we have valvular heart disease, some of those patients are more prone to atrial fibrillation, and so we need to look at that. We also want to know if the patient has any other arrhythmias or anything called a bundle branch block, which is really important when we talk about transcatheter aortic valve replacement. Next slide. We also do something called a CAT scan. Now, this is interesting because this wasn't something that was normally done during the workup for aortic valve replacement. And unfortunately, especially when I had patients sent to me in the early years of TAVR and where it would make, a big difference for somebody like you, Susan, is that artery, the aorta, can wind up becoming calcified because of that radiation. And sometimes there were patients who would get opened for open heart procedures and then get closed back up. So I can't imagine the disappointment that somebody would feel to be put under, have their chest open, and then have the procedure aborted because they couldn't clamp the aorta. So with this,
I've heard that called a porcelain aorta.
Yes, that's called a porcelain aorta. Mm-hmm. So if somebody ever gets told that they have a porcelain aorta, you really want to have conversations with your team before you have undergo open heart surgery. What the CAT scan does is it gives us a lot of good information. And as the years have gone in the past 10 years, we know a lot more about anatomy, and we learn a lot more about measurements using these CAT scans. And so what the CAT scan does is basically takes about 1 to 1.5 millimeter slices all the way from the chin down to the top of the thighs. And with that, what we do is we get the measurements exactly of that aortic valve. We also get the aorta, we get the femoral arteries, and that gives us really good information if there's any calcium or any aneurysms or anything that we need to be careful of with the anatomy when it comes to planning out these procedures. So the CT has become really an essential part of this workup for surgery. However, it should be known that CAT scans rely on using something called contrast. And contrast can be really, really bad for your kidneys. And so what we do is we do get a kidney function test before we give patients CAT scan and any of that dye. And if their creatinine's too high, we may do the CAT scan but not use any contrast. And that's where we might go to the echocardiogram's cousin, something called a TEE, which is a transesophageal echocardiogram, to be able to get some measurements of that aortic valve. So if you can't have contrast, it doesn't mean that procedures are no-goes. It's just that we have to protect those kidneys. And so we do work with the patient, and sometimes we just have to give extra fluid, or there's ways that we can work with you on this, but there are some patients who just shouldn't have contrast because of that kidney function. So be sure to discuss that with your provider. Next slide. In most cases, and again, this is where we go back to the CAT scan being so good. So the CAT scans now, and a lot of times, I can see calcium from the coronary arteries on that CAT scan. And if somebody doesn't have any calcifications, then and they're older or they've had issues, maybe we can forego the left heart catheterization. But especially in younger populations or in patients who are diabetic or patients who present with chest pain, the left heart catheterization becomes really important. And with that, what we do is we can either put a wire through the wrist or through the femoral artery, and we thread up this wire and we take pictures. We put contrast dye in the different blood vessels, and this is how we can tell if there's blockages in those blood vessels and if they need to be taken care of before the surgery or at the same time as a procedure. Next slide. So how do we decide why and when to intervene on aortic stenosis? So in patients who have severe symptomatic aortic stenosis, the overall survival is only 2 to 3 years without treatment. And when I say surgical treatment, I mean transcatheter or surgical treatment. And so for these patients, we really do want to get more aggressive about getting them treated. Next slide. So if you don't have any symptoms, if you have an ejection fraction of less than 50%, which is the squeeze function of the heart, then those patients should have their valve replaced. If you are asymptomatic, sometimes what we might do is put you on a treadmill to make sure that you're asymptomatic, or ask you to walk around with us to make sure that you're asymptomatic. And so we try to make sure that, again, going back to our earlier conversation about if you have symptoms and what feels normal for you versus what's not normal. We want to trust but verify, as they say. Make sure that, if you are symptomatic, we're catching it, because we know that it affects the mortality. So we want to be sure. Guidelines actually recommend watchful waiting. However, with that being said, there was a recent paper that came out of Japan that did show some improved survival in surgical patients who had surgery rather than that watchful waiting. And in the United States, we have a trial called the Early TAVR trial, which looks at patients who are asymptomatic. And so hopefully we should start to get some really good data from this trial. But what we do is basically, if somebody is asymptomatic, meaning they don't have symptoms, but they have severe aortic stenosis, they can take part in that trial. And about 50% of the patients get treated with TAVR right away, and 50% get monitored. However, if you do start to develop symptoms, you do get treated right away. Next slide. So I just want to go through the symptoms a little bit more and just explain why they're important. And we'll kind of go through this a little bit fast because I know there's a lot of other good information, and I want to make sure there's time for any questions that you may have. So when patients present, we'll call it heart failure, which is kind of the shortness of breath, fatigue, and swelling, maybe getting full really easy. So for these patients, they have changes in the left ventricular function. So the heart function may no longer be able to squeeze to get past that obstruction, so that stenotic area. And what they get is diastolic dysfunction. And this is just the function at the rest of the heart. So when the heart relaxes, it really, really relaxes and has a little bit of trouble waking back up to pump again. And so what happens over time is the heart gets really tired and it says, I can't beat up against this pressure anymore. And you start to see decreases in the ejection fraction. And for those patients, it's really important to get them treated as soon as possible. And there's no time limit. It may take 2 weeks, it may take 2 months, it may take 2 years, it may take 20 years. We don't have a magic answer for when we start to see that change. We just know that this is the general course of aortic stenosis. And about 50% of patients who complain of symptoms will have heart failure symptoms. Next slide. The next presentation that we frequently see in about 15% of symptomatic patients is people who have passing out or almost passing out. They might have super dizziness. And a lot of these patients, what happens is the coronary arteries are right above the aortic valve. So if your heart doesn't push out enough blood, not enough blood gets up to the head, and people start to feel really, really dizzy. And so especially if they have activity, that they'll start to get up and move really fast. Maybe they want to go out and cut their lawn, and then boom, they pass out. And a lot of times we can see that just because of that valvular heart disease. Next slide. The third symptom is angina or chest pain. And so these patients wind up getting, the heart muscle gets bigger. So you have to think it's working out because it's beating up against this pressure, and then it needs more oxygen to be able to function. And so what can happen is the heart can get bigger and it can start to compress the coronary arteries, and also then the patient's not getting enough outflow, and so they do get this chest pain. But that's also why when they rest, they feel better in a lot of instances, because then the heart can relax and it doesn't need as much oxygen. So about 35% of patients who have symptoms may have this type of symptom. Next slide. So how do we treat aortic valve disease? And we're going to talk about three options, which is medical management, surgical aortic valve replacement, and transcatheter aortic valve replacement. Next slide. So medical management. So this is a little bit of a misnomer. There's no medications that prevent or treat aortic stenosis. There's been some trials in the past looking at different drugs, whether it was statins or beta blockers or even chelation therapy. And unfortunately, none of these medicines worked really, really well. So the only time that we really can give medicines is really just to help ease the symptoms. So your doctor might put you on a diuretic to help with the water holding on to that fluid, or maybe a nitrate to help with that chest discomfort. But at the end of the day, unfortunately, it does not treat the aortic valve disease. Sometimes we can do a procedure called the balloon aortic valvuloplasty, which is where we open and stretch the heart valve. However, it doesn't fix it, and that stenosis does redevelop over time. Next slide. So we talk about surgery, and so surgery isn't that old either. So in 1955 was the first surgery with a heart-lung machine, and the first mechanical aortic valve was 1960. The first Ross procedure, which is taking the pulmonary system and putting it in the aortic valve system, was done in 1967, and the first porcine valve was done in 1969. Next slide. So there's largely two types of valves that are used. One is called a mechanical valve, and these are made of plastic, carbon, or metal. And one benefit of a mechanical valve is their durability. In many instances, and this is not a guarantee, that if you have a mechanical valve, that may be the only surgery that a patient needs to have, because that valve is designed to last for life, in quotes. And so for these patients, it's important to know that they do have some downfalls, and that is, you have to be on Coumadin. Looking at any of the other drugs that are out there right now that deal with anticoagulation, so sometimes you might see the commercials for Xarelto or Pradaxa or Eliquis. Unfortunately, none of these medications are proven to work with mechanical valves right now, so you do have to be on Coumadin. And some patients report the clicking, because you can hear the clicking of the heart valve opening and closing, that they find this disruptive and they have to sleep with a sound machine. You can also have a bioprosthetic valve, or something called a biological valve. And a lot of times these can be made from animal tissue, bovine, porcine, or human tissue. And the pros of this type of valve is no Coumadin. However, one big con is it doesn't last the lifetime. Depending on who you ask, if you ask a surgeon, you might hear that those valves last for 15 to 20 years. And what we're starting to see in a lot of the data, maybe it's a little bit closer to 10 years. Next slide. But some patients, however, may be better for an open surgery. And so there are some anatomical considerations that we have to think of. And some of those might be if the aortic valve area, where the valve sits, kind of the doorway to the valve, is very, very small. That patient may need something called a root enlargement. And that would be something that they may be better suited for surgery, depending on their age and their comorbid conditions. If you have an aneurysm that needs to be addressed and can be done at the same time, then those patients might need to have surgery. If you want to have a mechanical valve, then that would require an open heart surgery, or if you need to have bypass surgery at the time of the valve replacement. Next slide. So we also can talk about transcatheter aortic valve replacement, affectionately known as TAVR, or if you go to Europe, they refer to it as TAVI for transcatheter aortic valve implant. And so the first TAVI was done in a human, was done in 2002 in a city called Rouen, France, by Dr. Alain Crebier. And it was first done in the United States as part of trials in 2006. And what's really exciting is at Emory, we started as part of the trial in 2007. And so a lot of my first patients were patients who had been turned down for open heart surgery. And so really transcatheter valves were their only hope. And at the time, we randomized patients between treatment, which was the TAVR, or medical management, which unfortunately doesn't work. And so what they did is they took all of this data, and there have been other trials as well. And in November of 2011, they said for transfemoral patients who can't have open heart surgery, this valve is going to become available. And commercial availability for patients who were considered high risk for operations could have access to TAVR in 2012. Next slide. And what's really exciting is now we actually have TAVR for patients who are intermediate surgical risk and low surgical risk. So anybody working with their physician has access to TAVR, which is really exciting. And also, we have TAVR availability for what's called valve-in-valve. So if somebody had a surgical valve and that valve breaks down, either gets very stiff or very leaky, those patients have access to transcatheter heart valves now. Now, it's important to note that in the U.S. currently, the valve is only available for patients who are at high surgical risk. However, our hope is that this does change. And there are trials underway if patients did need to have a TAVR in TAVR valve, and that is being studied now. And again, that's important that we have to look at different anatomies, because we have to look at the size of the original valve, the size of the aorta, and the height of the coronary arteries to make sure we're going to be successful with that procedure. So why do TAVR? Well, these patients have faster recovery than open heart surgeries. They return back to their regular life, and it's very low risk comparatively. Next slide. So what's it like to recover from TAVR? So the average length of stay in the United States at this time is approximately 2 days. Some in one particular trial that started in Canada and was done at a few sites in the United States, they found that approximately 70 to 80% of their patients were discharged post-op day 1. So that is a huge change from open heart surgery and even from the old days of TAVR back in 2007. We do have to talk about medications post-transcatheter valve. There really isn't a consensus right now what that should be. In some places it's aspirin. In some places it's a drug called Plavix. In some places it's Coumadin. And so again, work with your provider, but don't stop any medications because you read somewhere that it might be right. Or, again, when we talked about those medications like Xarelto and Pradaxa and Eliquis, it says do not take if you have a heart valve problem. It hasn't been proven effective in mechanical valves, and it's also not proven to take as an anticoagulation in people who have atrial fibrillation secondary to a valvular heart disease. However, if you have a TAVR valve and your doctor advises you to take this type of medication, or your nurse practitioner or your physician assistant, please work with them before stopping those medications. We'll talk a little bit more about activity and follow up in the next couple of slides. Next slide. I just wanted to quickly cover some mitral valve disease points as well. And again, just like we talked about the leakiness or the stiffness, you can have leakiness or stiffness of the mitral valve. And so you can have something called mitral stenosis, which is stiffness of the mitral valve, or something called mitral regurgitation, which again is leakiness. And that's of two different kinds. That can be something called degenerative or functional. Next slide. So mitral stenosis is that valve gets stiff, just like what we saw in aortic stenosis, and those patients get high pressures across the valve. And most times we see this because the patient has had a history of rheumatic fever. So a lot of times they may not even realize that they had rheumatic fever, but they come in and say, I had strep throat like 100 times when I was a kid, and that's a red flag for me. or they may have been born with it stiff and congenital mitral stenosis, or they may have had endocarditis, which is an infection of the heart valves. And we treat mitral stenosis. One of them is minimally invasive, called a mitral balloon valvuloplasty, which is done through the groin, or those patients may need to have valve replacement. Typically, you cannot repair a stenotic valve just because of the calcium and the stiffness of the valve. They don't do well with repairs. Next slide. In mitral regurgitation, what happens is the valve is leaky and increases the pressure in the top left chamber of the heart, because when you think about it, that valve is supposed to be a one-way flow. So the blood goes from the top of the heart to the bottom of the heart, and what happens if that valve is leaky is then the blood goes back to the top of the heart, and then back to the bottom, and back to the top, and so on and so forth. So it's not a very efficient pump. And it can be caused by a problem with the leaflet, which is degenerative, or with the heart itself, and that's called functional. And it's important for your treatment team to know which problem is causing your mitral regurgitation. So if somebody comes in to me and says, I have mitral valve prolapse, a lot of time that leads me to believe that it's a problem with the leaflet itself. Or if they say they have something called a Barlow's valve, that again leads me to believe that it's a problem with the leaflets itself. If they come in and they tell me that they had a heart attack and they have damage to their heart muscle, I might think more functional. But again, it's important to work with your team as to what that might be. Next slide. So when we talk about symptoms of mitral valve disease, patients may have palpitations. They might have shortness of breath, especially with activity, passing out episodes, numbness in the hands or feet, or chest discomfort. And it's really important to note as well that patients who have mitral regurgitation, if it comes on acutely, meaning that it's an immediate, it's an emergency, that somebody did damage to their muscle of their heart, those patients need help fast, because what happens is they get super short of breath because that heart can't accommodate all that increased flow. Patients who've had leaky valve over time tend to do better because their heart tends to accommodate having that leakiness. And so for those patients, you might not do any treatment when they're mild or moderate, but once they get to severe, that's when we have to start about what to do. Next slide. So how do we treat mitral regurgitation? So again, when we talked about the functional mitral regurgitation or damage to the heart itself, one of the best things that we have is something called medical management. There are some medicines that have been proven effective to be able to manage that heart failure, or maybe the patient needs a specific type of pacemaker that paces both sides of the heart at the same time. And a lot of that depends on the function of the heart, what caused the problem, what medications that they're already on. But then we also saw that there are some percutaneous therapies that may be options for those patients as well. So patients who have mitral regurgitation in general are candidates for something called surgical repair, and that may be done through a robot where they just make the laparoscopic surgery essentially for the mitral valve disease. Minimally invasive, which is they make about a 1.5-inch incision on the right side of the chest to treat the mitral valve, or they may need to have traditional surgical access, which is the full sternotomy. Or they may be a candidate for something called a MitraClip, which is a percutaneous clip that they can put on for leaky heart valve. And that, again, can be whether it's functional or degenerative. Now, the one thing in the United States right now, that's only approved for certain patients. So, again, if you're going to be considered, it's best to go for a workup with a heart team that offers this type of therapy. And for replacement, if that leaflet actually needs to be replaced or the valve needs to be replaced, surgically you can do robotic, minimally invasive, and also traditional surgery. And there are some that we can do percutaneous therapies. And again, just like on the aortic side, you can have valve and valve. You can have valve and valve on mitral. And there's some trials that are underway to do valve in just the native mitral. But again, you would have to go to a center that specifically offers that type of therapy. Next slide. So when we talk about recovery, people who have traditional surgical repair or replacement, so the full sternotomy, it's usually about a 5-day to 7-day length of stay. about 4 to 6 weeks recovery with limited to no driving and limited lifting. Here at Emory, we don't let people lift more than 10 pounds for the first 4 weeks that they have their procedure, and we don't allow them to drive either. With percutaneous therapies, if they're having a mitral valve repair, we do have them limit their lifting, no tub, whirlpool, or hot tubs for approximately 5 days and no driving for a week. So again, the recovery from a potential percutaneous repair versus a surgical repair or replacement might be much different. Next slide. The other items that we have to discuss is, where does the patient recover? Sometimes with open heart surgery, they might need a little bit extra assistance and might need to go to a rehabilitation center for a few weeks versus being able to go home with family support. We do have them monitor their site care as to, what does the groin look like or what does the chest look like? We want to monitor for signs, symptoms of infection or complications. We talk about medications. For a lot of patients post-surgery, we want to make sure that they're on beta blockers. We want to make sure that if they needed any anticoagulation, depending on what kind of valve that they have, or if they got a transcatheter aortic valve, that we want to make sure that they have aspirin. If they had a stent, what kind of medicine do they need to be on? And so we do work, and depending on what type of procedure you have, that will determine what kind of medications you need. We do encourage nutrition. So again, eating is so important. Patients who don't eat have a tough time recovering because they just don't have that energy. And so sometimes, depending, especially in our surgical patients, we might have to give a little Ensure or even Pedialyte to make sure that they're meeting those nutritional needs and staying hydrated as well. And then what type of activity are they doing to get up and walk around, whether or not they can get into the shower, and what those limitations are. Next slide, please. We do have patients follow up, and whether you have surgery or a transcatheter valve, we do have you seen in 1 month. And we work with your cardiologist or primary care physician to get you seen, usually within 1 to 2 weeks, because we want you to check back in. Otherwise, we do have some providers who say, I will see you after you follow up with the surgical team. But it is very important to work with your valve team to be seen 1 month after your procedure. If you are part of a clinical trial, that's the follow-up's determined as part of that clinical trial. So I don't want to speak across the board because some people may belong to a specific trial that has specific follow-ups. And for patients who have any kind of transcatheter therapy, we do want to see you back in the valve clinic at 1 year. And honestly, our site wants to see you yearly thereafter. We want to be part of your care team for the rest of your life. And so that becomes an important part of that follow-up. Next slide. One other item that I just really wanted to touch on that I think is so important is something called cardiac rehabilitation. Now, cardiac rehabilitation, it sounds really almost like I'm sending people to a nursing home, and that's not what cardiac rehab is. It's kind of like a personal trainer. And so for patients who have TAVR or SAVR or mitral valve disease or angioplasty or bypass surgery, all of these patients should be offered to go to cardiac rehab. And typically it's set up in 3 phases. There's phase 1, which is basically you go, you work with the team, they hook you up to the heart monitor, they show you the exercises, and usually that's a few visits. And then the next phase, phase 2, is basically you get hooked up to the monitor and you're monitored by the team. However, you're kind of going around and doing the gym by yourself. And it is kind of a gym. Now, the great thing about Medicare is Medicare typically pays for phase 1, phase 2 of cardiac rehab, which essentially is 36 visits. Now, for people who want to do phase 3, it's kind of like joining the gym. And so they don't have to monitor you anymore. You just get to do the weights and do the exercises just in a specific monitored condition. Now, I will say that I have patients who have been doing cardiac rehab for 20 years, and maybe it's become a little bit social. They really like the activity. And so it's really important for them to be part of that group. And again, there have been a number of papers that have come out to say patients who do cardiac rehab do better than patients who don't do cardiac rehab. So I do encourage patients to follow up about cardiac rehab. Next slide. So in closing, valvular heart disease, it's a chronic condition. Unfortunately, it's just not something that you have and, the leak may get better or things like this depending on medicines, but it is something that has to be monitored for life. And work with your valve clinic to not only determine options for treatment of mitral valve disease, but any valvular heart disease. And if you have more, and what's really important, and this is the point that I really, really want to stress, is patients have more choices than ever for treatment than valvular heart disease, whether it's open, whether it's minimally invasive, whether it's robotic, whether it's percutaneous therapies. And so really having that conversation with the heart team is so important. We want to honor your wishes, but we want to make sure that you have the information that you need to be able to make the best decision for you. So I just really want to stress that work with your heart team, because that's why we do this. We do this to take care of patients and to help you. So trust in us. If you have any questions or concerns, please don't be afraid to ask. Next slide. So thank you. This is Emory. This is Atlanta, Georgia. It's rainy and yucky today, but it's still about 75 degrees. So if anybody ever wants to come and visit, let me know.
Tricia, thank you so much. That was wonderful information. And I'm sure no patient has gotten that much information in 1 hour's time. And it's wonderful to have. Thank you. This will be something that is valuable for a long time for patients. We have received a few questions, and I know we only have about 9 minutes, so I'm going to just jump right into the questions. We have a question that says, right after TAVR, I was diagnosed with heart block and required a pacemaker. What causes heart block? Could you explain that? And could you also talk about maybe the risk for a pacemaker after a TAVR?
Absolutely. So, again, when we talk about, there's two different kinds of specialty heart doctors sometimes. We have the plumbers and the electricians. And so most of your TAVR people are plumbers, and then we have the electrical team. And it's really important to know that right under your aortic valve is the start of the electrical system of the heart. So during a TAVR, what we do is we put in a pacemaker, and it's just a simple wire that rests in the right side of the heart most times. And what that does is during the procedure, if you go into heart block, and with certain types of valve, we use it to make the heart beat fast when we actually place the valve. But if you go into heart block, that's there to protect you, because we know exactly where that valve sits. About a millimeter away is where the heart rhythm center is. And when we talked about EKGs before, there are certain people I know have more likelihood of developing a heart block than others. So if somebody came in and they already had a left bundle branch block or a right bundle branch block, I know that those patients are at higher risk. So typically we tell patients if they have a balloon expandable valve, the risk of pacemaker might be about 5 to 8%. If patients have a self-expandable valve, that might be from 10 to 25%, depending on the type of valve. And if a patient comes in and they have a right bundle branch block, I know that their risk is going to be generally higher. So again, part of that determination, there's some of it that we look at the anatomical factors beforehand that can tell me whether patients are going to have heart block. And then some of it is just those patients get irritation of the electrical system because of where that heart valve sits. And so that's why people can develop what's called complete heart block after the procedure. Now, complete heart block is something that has to be addressed. It isn't something that, some patients might get conduction back. The problem is if you don't, those are the patients who pass away and have sudden death because their heart goes into a rhythm that doesn't keep up with their vital functions. So it is important to make sure that that is addressed. And that's also why we put people on telemetry after their procedure, because we do want to monitor that heart rhythm.
Could you explain what telemetry is?
Sure. Telemetry is basically a mobile heart rhythm monitoring device. And so patients who are in the hospital, what happens is they put on like 5 little electrodes on their heart, and it sends a transmission to a room, to basically a TV, where we have specially trained monitor techs who look at patients' heart rhythms. And so their job, their only job, is to look and see if the patient is having any problems with heart rhythms, and then we can act on that very, very quickly.
Wow, that is some really great close monitoring that happens for heart patients.
Absolutely. And for some patients, we may think, okay, you know what? That rhythm doesn't look 100% normal, but I don't want to put I don't want to put a pacemaker in yet. And so for those patients, you might have to go home with what's called a mobile monitor or a Holter monitor. And those
Mm.
comes in all shapes and sizes. Some of them now are just a little patch that goes on the left side of the chest, and some of them are very similar to what's used in the hospital. Some of them go through apps on phones. I mean, so I wouldn't venture to guess what would happen at your specific site. However, it is important to know that that is something that will continue to be monitored, is looking at those heart rhythms. And when patients come back for a 1-month follow-up, they will get an EKG to look at that rhythm as well, and also at 1 year.
Okay, thanks. We have another question about will I need to have a TAVR replacement again in 10 years? And I would like to add a little follow on to that too. When you're answering that, perhaps you could tell us a little bit more about valve-in-valve replacement. You had mentioned that earlier in your talk about sometimes being able to do that with an initial surgical valve that's a tissue valve, and then also a valve-in-valve with TAVR. And we're wondering um, if there are restrictions right now as to who can receive a valve-in-valve. So,
Absolutely.
okay.
So, the possibility, as with even surgical valves, is transcatheter valves right now don't show any early signs of degeneration. They don't show that they don't last as long as surgical valves. And they go through what's called bench testing, which means that they simulate years and years and years worth of heartbeats to make sure that believe these valves are going to work. When we study things, and we can do something called the retrospective analysis, which means that we can go back and we can look at patients who had procedures. And right now, we don't see that there's any what we call early degeneration, or those valves aren't lasting as long. But it is important to note that just like surgical bioprosthetic valves, TAVR valves are not designed to last for 20 to 30 years. If they did, that is a blessing, and we will give thanks. But again, we know, just like with surgical valves, it's just we know that they're going to wear out. So how do they get replaced? So right now, there are trials going on that look at TAVR valve-in-valve. Which means that if you have a TAVR valve that's developed a lot of leak or a lot of stiffness, they look at putting a transcatheter valve inside of a transcatheter valve. That is not approved for use in the United States as of yet. I wouldn't venture to guess to say that nobody is going to do that for you. But at the end of the day, that is not an FDA approved indication for that device. Now, for surgical valves, if the patient is high risk or prohibitive risk, then that is an approved use. And again, it's not like aortic stenosis to get a transcatheter valve in the U.S. on label or as indicated by FDA. Those patients have to have aortic stenosis. For valve-in-valve, you just have to have had a surgical valve that broke down. So it can be leaky or it can be stiff, which is really important to note.
Okay, that is good clarification. And I have learned a lot during this. Um, Thank you so much. I was wondering if you could qualify a little bit, or in this last minute, about palpitations. We talk about palpitations, but I'm not sure if if you don't know what a palpitation is, how do you know you're having one? Could you give us a little bit of insight about that so people know if they're having palpitations?
Yeah, absolutely. So the way that people describe palpitations is it feels like a fluttering in your chest or your heart is racing, or maybe you can feel your heartbeat really, really hard. And some people even say that it's very loud, that they can just feel that their heart is going maybe faster than it should. And for those patients, that's how we hear that they have palpitations. Now, they can have that symptom. Sometimes they can have shortness of breath with it. Sometimes they can have lightheadedness with it, or sometimes they just might feel that that heart is beating fast. And that's how we describe the palpitations.
Okay. So if you notice a heartbeat, because usually we don't notice our heartbeat when things are going well. So basically, if
Right.
something causes you to notice your heartbeat and you're not exercising, then that's most likely a palpitation.
It potentially, yes, ma'am.
Yeah. Okay. And one quick last question. How do you tell the difference between like normal swelling or swelling that's not concerning versus swelling that could be an indication of heart failure?
Right. So I think one of the things is people have swelling for lots of different reasons. Some of them might be because of diet. So the more salt you eat, the more fluid people tend to retain. That's why when we go out for big Chinese food dinners, you might have some swelling in your legs. And a lot of time when you raise your legs, that swelling gets better.
Hmm.
And for patients who have swelling because of their heart, a lot of times they wake up with swelling. They wake up with swelling, they go to bed with swelling. And it might be, really just you have to take water pills to get it away. And a lot of times it comes with some other symptoms as well, that maybe um, you get full easier than you used to because you have swelling in your belly. And some people don't have swelling at all. So again, there's no magic when it comes to edema or swelling. We just kind of ask about some other symptoms when it comes with it. Does it get better when you take your medicine? Did you have a big salty meal? Because some people can also have what's called dependent edema because they're on their feet all day. And in some cases, compression hose and things like that work. However, if you do have a heart valve problem and you're having swelling, it is best to get checked out.
Yes. Thank you so much. We have used every moment of our hour. Thank you. Your patients are so lucky, and we are so lucky to have had an hour of your time today, Tricia. Thank you
Oh,
so
I'm
very much.
incredibly grateful. Thank you so much for allowing me this opportunity.
Thanks. And everyone, we will have this is being recorded, and we will have a link to the recording. So if you would like to share it with someone, listen to it again, someone wasn't able to make it, they'll be able to get an access to the recording, and it will stay on the Heart Valve Voice US website for a very long time. So thank you again, everyone. Have a great day. Those of you who are in the snow, be safe, and we'll see you again next time.